This program is brought to you by Emory University.
All right, so Faisal Merchant, for those of you guys who I haven't had a chance to meet yet, one of the EPs over at Midtown. We're going to be talking mostly about pharmacologic management of arrhythmias and specifically antiarrhythmic drugs. So feel free to stop me if you have questions as we go along, or you can put them on the chat and I'll try to keep an eye on that also. And hopefully we'll have a few minutes for questions at the end. But basically what we're going to do is divide the talk up into a couple different sections. The first section, we're just going to talk a little bit about basic pharmacology as it specifically pertains to antiarrhythmic drugs. We'll talk a little bit about mechanisms of specific arrhythmias. And then the bulk of the talk, the second half, we'll talk about specific classes of antiarrhythmic drugs, focusing on the class 1 and class 3 antiarrhythmics. So I know it's painful to look at a slide like this at 7:30 in the morning, but understanding the basics of depolarization and repolarization in a myocyte is important to understanding how the antiarrhythmic drugs work. So if you picture a myocyte here for average myocytes, the resting membrane potential is about -90, and that's primarily determined by the gradient between potassium and sodium inside and outside the cell. So if you think back to your basic pharmacology, the sodium-potassium exchanger pumps sodium out of the cell and pumps potassium into the cell. And that gradient gives you a resting membrane potential of about -90. When a wavefront of depolarization comes along and depolarizes this cell, initially the sodium channels open, which allows a massive influx of sodium into this cell. And that's phase 0. That's opening of sodium channels, which leads to depolarization and makes the resting membrane potential positive. We'll talk a little bit about ITO, which is one of the repolarizing currents. Phase 2 is sort of the plateau that is maintained by an influx of sodium and an efflux of calcium. And then phase 3 is repolarization, in which potassium leaves the cell, and that repolarizes you back down to -90. So sodium influx, phase 0, potassium efflux, phase 3. But basically the important things to remember are that depolarization in the myocyte is mostly mediated by sodium channels. Repolarization is mostly mediated by potassium channels. That's the most important thing to remember. If you overlay the action potential of a myocyte on an actual surface 12-lead EKG, forget about the P wave right now and just focus on ventricular events, which is the QRS. Phase 0 here, the opening of sodium channels, which corresponds to the onset of depolarization, will time with the onset of the QRS. So basically, the phase 0, the action potential, beginning of the QRS. The plateau phase here, phase 2, is basically the ST segment. And then the end of the T wave is repolarization, which is what gets you back down to the resting membrane potential. So phase 3 really corresponds to the end of the T wave. So the action potential actually corresponds pretty well to the QRS and T waves on an EKG. And again, just to reinforce, depolarizing currents are sodium, repolarizing currents are potassium, and we're going to keep saying that over and over again. It's an important thing to remember. Just to remember that the ultimate goal of depolarization for most myocytes is in order to initiate contraction. And during phase 0, when there is an influx of sodium into the cell, that the positive current then causes calcium. You also get calcium coming into the cell and results in calcium-induced calcium release from the sarcoplasmic reticulum. And it's actually the calcium which allows excitation-contraction coupling in order to actually generate mechanical systole. And not surprisingly, mechanical systole is a little bit delayed from electrical systole and the electrical events that we've been talking about, because the electrical events that lead to depolarization in the myocyte take a small bit of time in order to generate this calcium-induced calcium release and lead to mechanical contraction. It's the same reason that you see the waveform on, for instance, a line tracing a little bit delayed in terms of mechanical systole from the QRS complex, because the mechanical events take a little bit of time following the electrical events. So that's as much as we're going to talk about basics and ion channels. So now we're going to segue a little bit into talking about mechanisms of arrhythmias. And there are really 3 big categories of mechanisms of arrhythmias that are important to keep in mind. One is automaticity. And what automaticity means is that there are certain cells inside the heart, certain myocytes, and this is true both in the atrium and in the ventricle, that have this ability of phase 4 depolarization. meaning when the membrane is all the way down at -90 at that resting membrane potential, they tend to spontaneously depolarize and initiate another action potential. And that phase 4 spontaneous depolarization is known as automaticity. Now, this SA node is the area in the heart high up here that has the fastest rate of automaticity, and that's the one that sets the rate for the rest of the heart most of the time. But occasionally you can have other areas in the heart that will develop abnormal automaticity, and that can be a cause of focal arrhythmias, focal PACs, focal atrial tachycardias, some focal PVCs, and even focal VTs can be due to enhanced automaticity. But one potential mechanism of arrhythmias is automaticity. And automaticity can be influenced both by autonomic and physiologic inputs. So as you're resting, as your heart rate exercise and your catecholamine levels go up, that causes the SA node to depolarize spontaneously faster and faster, and you end up with sinus tachycardia, which is what should happen when you're exercising. So as we said already, there are a number of arrhythmias that can be due to automaticity. Generally, we think of focal arrhythmias as being either automatic or due to something called triggered activity, and we'll talk about, a bit about triggered activity. And then there are reentrant arrhythmias, and reentry can be either due to anatomic reentry or functional reentry. I put these on here mostly for the sake of completeness. I don't want you to get too bogged down into trying to figure out the specific mechanisms of arrhythmias, only because sometimes we can't tell the difference very easily. Sometimes it can be very hard to tell a micro-reentrant arrhythmia from a focal rhythm, so it's not worth getting too bogged down in there. And the other thing is that you would think that if you knew the mechanism of an arrhythmia, you could use that to make some rational decision about what antiarrhythmic drug to use. But the truth is it doesn't really work that way. We sort of empirically make decisions about antiarrhythmics based on the clinical profile of the patient more than we do on what we think the specific mechanism of arrhythmia is. But as we said, focal arrhythmias can either be due to enhanced automaticity, which we talked about already, and it's this phenomenon of phase 4 depolarization, which can be affected by catecholamines and various other autonomic inputs. And the SA node tends to have the fastest rate of automaticity, although you can have other areas in the heart that develop abnormal automaticity, and that'll result in faster heart rates or arrhythmias due to abnormal automaticity. The other big cause of focal arrhythmias is something called triggered activity. Triggered activity comes in two varieties. There are early after depolarizations and delayed after depolarizations. Again, the specific mechanisms here are less relevant. I'll try to highlight the clinically important stuff to remember. But early after depolarizations are these little blips that occur during the preceding action potential. So here's an action potential here, and this little blip of calcium release here that occurs before the end of the action potential can initiate another wavefront, and this is known as an early after depolarization. You can also have delayed after depolarizations, and this is a little blip of calcium release here within the cell that occurs after the end of the action potential duration, and this is a delayed after depolarization. So both early and delayed after depolarizations can lead to arrhythmias because of these little blips that occur when they should not. The thing that's important to remember clinically is that early after depolarizations, these blips that occur during the preceding action potential, are the mechanism for long QT mediated torsade. So torsade, long QT, early after depolarization. So I want you to remember that. And the reason that that occurs is that when your QT interval gets long, you can imagine that your action potential duration is also long. And the longer the action potential, the higher the likelihood, just based on probability, that you're going to have one of these little calcium release events within a myocyte, which can sometimes happen spontaneously. But the theory during torsade, we always think about torsade as being due to this sort of R on T phenomenon or PVC that occurs on the preceding T wave. But the reason that that PVC occurs is actually this early after depolarization, which gives the result to that PVC that then initiates torsade. So long QT, torsade is usually due to early after depolarizations. In contrast, delayed after depolarizations, these little blips of calcium release that occur within the cell after the end of the action potential, this is most commonly the mechanism of arrhythmia that occurs with digoxin toxicity. We'll talk a little bit at the end of the talk about the mechanism of digoxin, although it's not specifically an antiarrhythmic drug, but we do use it for arrhythmias. But digoxin can cause a buildup of calcium within the cell, which makes it more prone to developing these delayed after depolarizations. And when people get dig toxic and they develop arrhythmias, usually those arrhythmias in the setting of dig toxicity are due to delayed after depolarizations. So long QT, early after depolarizations, torsade, calcium overload, digoxin toxicity, delayed after depolarizations. So the focal arrhythmias that we talked about are either due to enhanced automaticity or after depolarizations, either early or delayed after depolarizations. Reentry is the other big mechanism of arrhythmias. And in reentry, in essence, you end up with a reentrant circuit going around and around some obstacle. And this obstacle here in green, just in this schematic, can either be some anatomic obstacle. The most familiar to you would be cavo-tricuspid isthmus-dependent flutter or typical flutter, where the obstacle is actually the tricuspid annulus and the reentrant wavefront is going around and around the tricuspid annulus. Or sometimes these can be functional, meaning they occur, they're not fixed anatomic, but they can be, they can have functional characteristics. But either way, you need some obstacle in order to have reentry around and around. And reentry obviously is different than focal arrhythmias that are due to enhanced automaticity or triggered activity. A good example of reentry, you guys are all pretty familiar with that, but for instance, if you have WPW and you have conduction down the AV node and you've also got an accessory pathway, say a left-sided accessory pathway, you can have orthodromic reentry tachycardia where you conduct down the AV node through the ventricle and back up the accessory pathway going round and round, and that's the mechanism of SVT or orthodromic reentry due to WPW. So reentrant arrhythmias are also pretty common. If you were to try to broadly categorize most of the arrhythmias that we see in clinical practice, most of the focal arrhythmias are focal atrial tachycardias, PACs and PVCs tend to be focal. And a lot of the idiopathic VTs, so outflow tract VTs, or when you see somebody having outflow tract PVCs, those are usually focal, meaning they're not reentrant going around and around some obstacle. And whether they're focal due to enhanced automaticity or focal due to triggered activity can sometimes be hard to tell based on clinical basis. Reentrant arrhythmias, AVNRT is a reentrant arrhythmia going around a slow and a fast pathway. AVRT with an accessory pathway we talked about. Atrial flutters like typical atrial flutter are reentrant. And then most of the scar-based VTs, meaning VT that you see in people who have had prior MIs, where the prior area of infarction serves as the scar, those are all reentrant arrhythmias. So that's sort of a broad categorization of arrhythmias based on putative mechanisms. So now we're going to segue and talk for the rest of the talk about specific antiarrhythmic agents, which is really the focus of the talk. And a couple of things to remember about antiarrhythmic. So one is that there will be antiarrhythmic and pharmacology questions on the general cardiology boards. There always are. And most of them are generally pretty easy and should be questions that you can get quickly and move on to the more complicated questions. But a lot of this will show up on the general boards, and I'm going to try to highlight some of the specific kinds of toxicities and pro-arrhythmias that they like to highlight on the boards. But for any antiarrhythmic drug, all antiarrhythmic drugs can have pro-arrhythmic side effects. There's no free lunch with antiarrhythmic drugs. Just by virtue of the fact that you're trying to manipulate cardiac conduction, the risk for developing or making somebody pro-arrhythmic always exists. And because of that, anytime you're using an antiarrhythmic, you want to make sure that the benefits of using the antiarrhythmic drug outweigh the risks. A lot of the antiarrhythmic drugs, the class 1 and 3s in particular, which is where we're going to focus, have a pretty narrow therapeutic index, meaning that if they're subtherapeutic, they're ineffective, but if they're super therapeutic, they can be risky and pro-arrhythmic and cause specific pro-arrhythmia syndromes. And the other thing that makes antiarrhythmic drugs hard to study, at least, is that a lot of them have multiple actions. So it's not like this specific drug inhibits this specific channel, and that's the way it works. Most of them are somewhat promiscuous from an ion channel biology point of view, and you'll see that as we go along. But many of the antiarrhythmic drugs bind multiple kinds of receptors. So you guys will all be pretty familiar with this Vaughan-Williams classification of antiarrhythmic drugs. It's probably worth remembering the 4 broad classes of drugs, but the class 1 antiarrhythmics are sodium channel blockers, and they get broken down into class 1A, class 1B, and class 1C. I've put down the major effects of each of those categories on here, but again, remember that each of the drugs within those specific categories can bind to different channels, and their actual effect can be somewhat different. So we'll go through each of those individually. The class 2 antiarrhythmics are beta blockers. You guys are all plenty familiar with beta blockers. The class 3 we're going to spend some time on are primarily sodium channel antagonists and block repolarization. And then the class 4, again, you guys are pretty familiar with calcium channel blockers. So we're not going to spend a lot of time talking about beta blockers and calcium channel blockers. We're mostly going to focus on the class 1 and class 3 antiarrhythmics. So we're going to start out going through the class 1A antiarrhythmics. This is quinidine, disopyramide, and procainamide. The one thing that I will say about class 1A antiarrhythmics is that they are very rarely used clinically because they are very promiscuous drugs. You'll see I've got the mechanism listed here, but most of them bind to multiple channels. And they also have a lot of specific toxicity. So it's pretty rare in clinical practice for us to use class 1A antiarrhythmics. The reason I put them on here is that they do have some specific usages, which are pretty important to know, particularly for the boards. And some of them have very specific toxicities that are also important to remember for the boards. But the first class 1A is quinidine. As you can see, it's got multiple actions, primarily a sodium channel blocker, which is why it gets clustered in with the class 1s. But it does also block potassium channels, so it can also prolong the QT interval. So it's got several different effects. It's mostly hepatically metabolized. The important thing to remember for quinidine is that quinidine is the drug that we typically use for treating Brugada syndrome. So if people have Brugada syndrome and they're having recurrent arrhythmias, quinidine is usually the drug of choice. The important toxicities to remember for quinidine is that it frequently can cause thrombocytopenia, which we think is immune mediated. But the two things I would remember about quinidine is its use to treat Brugada syndrome and the immune mediated thrombocytopenia. The reason that quinidine is used to treat Brugada syndrome is that in addition to its sodium channel blocking activity, it also blocks this channel called ITO, which if you remember back to one of our original slides, ITO is a channel that is operative here during phase 1. It's actually responsible for this initial dip at the end of phase 0. And in patients who have Brugada syndromes, for reasons that we don't understand very well, the activity of ITO particularly in the right ventricular outflow tract, seems to be more heterogeneous than it should, and that can lead to reentry in arrhythmias. And quinidine, by blocking ITO, can suppress arrhythmias in the setting of Brugada syndrome. So that's the important thing to remember about quinidine, is that it blocks ITO and it can be used to treat Brugada syndrome. Procainamide is the next class 1A antiarrhythmic. Again, it has multiple activities. The things that are important to remember about procainamide is it's actually converted in the liver to N-acetyl procainamide, which is the active metabolite, which is then renally cleared. So you have to have both a healthy liver and a healthy set of kidneys in order to use procainamide. And as you can imagine, a lot of the patients in the hospital either have some hepatic dysfunction or renal dysfunction, which makes procainamide not a very good agent to use. The most important things to remember about procainamide is that it's used not to treat Brugada syndrome, but it's actually the drug that we use to provoke Brugada syndrome. If you want to do a diagnostic test for somebody in whom you're concerned they may have Brugada syndrome, you can give them procainamide. So this is a good example of why these drugs are hard to class together based on their mechanisms. For two drugs within the same class, both 1A antiarrhythmics, quinidine is used to treat Brugada syndrome and suppress arrhythmias. Procainamide is used to provoke Brugada syndrome or Brugada pattern and make a diagnosis of arrhythmias. So within the same category of drugs or same class of antiarrhythmics, the two drugs have very different effects. The other thing that's important to remember about procainamide in terms of the boards is that there is a phenomenon of procainamide-induced lupus, of drug-induced lupus, that goes along with procainamide. So that's important to remember. If you're concerned somebody has Brugada syndrome, you see this weird pattern of an incomplete looking right bundle branch block on some of the right precordial leads, you can give them an infusion of procainamide and actually provoke the Brugada pattern. So this would be a positive procainamide challenge if you gave somebody procainamide and you're looking for Brugada syndrome. So the way to test for Brugada syndrome is to give them procainamide. The way to suppress arrhythmias with Brugada syndrome is quinidine. This is what drug-induced lupus looks like. A lot of the features are fairly similar, although there are some differences in the phenotype of drug-induced lupus compared to conventional autoimmune lupus. But again, drug-induced lupus is one of the sort of board review kinds of questions that come up for Procainamide. Disopyramide is the third class 1A antiarrhythmic that people often talk about. Again, it has multiple actions. It's really very rarely used these days. The one area where we do sometimes use disopyramide is not actually for an arrhythmia, but you can actually use it to treat LV outflow tract obstruction in people who have hypertrophic obstructive cardiomyopathy. And so occasionally if somebody has HOCM and they also have Afib, in order to try to be parsimonious and to treat two things at one time, we'll sometimes use disopyramide. But I will say it has a lot of anticholinergic effects. If you give it to older gentlemen, they all get urinary retention. And the anticholinergic effects really make it hard to use, which is why we don't use disopyramide a whole lot. But that's the one situation which occasionally we would use disopyramide. But those are the three big class 1A antiarrhythmics. Like I said, they're clinically going to be used very rarely outside of either diagnosis or treatment of Brugada syndrome. They're mostly important to know for historical purposes and because of the toxicities, because they sometimes show up on the boards. The class 1B antiarrhythmics we do use pretty common clinically. You guys are all familiar with lidocaine. The class 1Bs are lidocaine and the oral version of lidocaine, which is Mexilitine. Lidocaine is a relatively pure sodium channel blocker, so it slows depolarization. It's hepatically cleared. The one important thing to remember about lidocaine is that it does not really bind to any sodium channels in the atrium, which is why you don't use lidocaine for atrial fibrillation. You only use it for VT. So every now and then you guys will do a consult on somebody in the MICU who's got AFib or something, and they'll put them on lidocaine and nothing's happened. It's because lidocaine doesn't really have any role for atrial arrhythmias. It's mostly used for VT. The big toxicity associated with lidocaine is that it is a sodium channel blocker and it does cross the blood-brain barrier and it can cause CNS side effects and seizures, particularly for people who are on lidocaine for a long time. So if somebody's on lidocaine for more than a few days, you're having trouble waking them up, getting them off the vent, they have a seizure, remember to think about the lidocaine as a cause. Mexilitine is basically the oral version of lidocaine. It does almost exactly the same thing, similar profile of toxicities, similarly no role for atrial arrhythmias, which is why you don't use Mexilitine for AFib. One thing about Mexilitine is that although we do use it, it's kind of a salvage. Usually those people are already on Amiodarone and they're still having arrhythmias, VT, and we'll try to put them on Mexilitine. The reason we don't jump to using Mexilitine more is it's just not very effective. It's not nearly as effective orally as lidocaine is intravenously, but they basically have the same sort of profile. The class 1C antiarrhythmics we're going to spend a few minutes talking about because these are antiarrhythmics that we use quite a bit clinically. They are almost always used for atrial fibrillation in relatively structurally normal hearts. We use these a lot in EP, mostly in outpatients. It'd be unusual for you to start a class 1C antiarrhythmic as an inpatient. We use them in outpatients with AFib all the time, but the two class 1C antiarrhythmics are Flecainide and Propafenone. And again, we mostly use them for atrial fibrillation. They are both relatively pure sodium channel blockers. Flecainide is more renally cleared than hepatically cleared. Propafenone is the opposite. But again, they're both primarily used for atrial fibrillation. And the one thing I want you to remember, well, there's two things I want you to remember about the class 1C antiarrhythmics. One is that they have this phenomenon of use dependence, which we're going to talk about in a second. And two is the CAST trial. And we're going to talk about both of those. But the two things to associate with class 1C antiarrhythmics are use dependence and the CAST trial. Propafenone is basically the same as Flecainide, except it's more hepatically cleared than renally cleared. But again, primarily used for atrial fibrillation and the same sort of deal with use dependence and the CAST trial. So let's talk about use dependence. So what use dependence is, and this is where, remember we said at the beginning that a lot of antiarrhythmics also can have pro-arrhythmic side effects. And one of the pro-arrhythmic properties of class 1C antiarrhythmics in particular comes from this phenomenon of use dependence. So Flecainide and Propafenone primarily bind to sodium channels. The interesting thing is that they mostly bind to sodium channels when they are open. If you think back to basic pharmacology, these ion channels, they open, and then they're in an inactive state, and then they recover and they're ready to open again. So for any given channel, it spends some of its time in the open state, some of its time in the inactive state, and some of its time in the recovered state waiting to open again. Flecainide and propafenone only bind to open channels, which means that the higher the probability of a channel being open, the more quickly it's being depolarized, the more binding you get and the more drug effect you get. And that's actually pretty useful for Afib. If you're in sinus rhythm right now, that means that the myocytes in your atrium are only opening, say, 60 or 70 times per minute. And the effect of the propafenone or flecainide, if you take it on a regular basis for Afib, is relatively blunted. But if all of a sudden you go into Afib, now your atrial myocytes are depolarizing 300, 400, 500 times per minute. And those sodium channels in the atrium are opening much more frequently. And so the drugs are more likely to bind and have an effect. And so the use dependence can be helpful for atrial arrhythmias. The problem is that use dependence can also affect the QRS. And when you get tachycardic, either because of sinus tachycardia or because you go into some arrhythmia, the binding of flecainide and propafenone to sodium channels in the ventricle can cause widening of the QRS because it's slowed depolarization so much that your QRS is now starting to get wider, and that can lead to pro-arrhythmia. So one of the things that we'll sometimes do in people who are on flecainide and propafenone is do an outpatient treadmill test to make sure that their QRS doesn't get too wide when they exercise and their heart rate goes up, to monitor for this phenomenon of use dependence. Because flecainide and propafenone can cause this use-dependent QRS widening, we also tend not to use them in people who have a baseline wide QRS unless they have a pacemaker. If they have a pacemaker, then you don't have to worry about it so much. The other pro-arrhythmic thing that can happen pretty frequently with class 1C antiarrhythmics is, remember, these drugs block sodium channels and they slow down conduction. Now imagine if you've got atrial flutter going at 300 beats per minute in your atrium, your AV node isn't going to conduct from atrium to ventricle at 300 beats per minute, but it's pretty content to conduct 2 to 1 at 150 beats per minute, which is why it's so common to see atrial flutter 2 to 1 at 150 beats per minute, because the AV node won't conduct at 300 beats per minute. But if you put somebody on flecainide and propafenone and they develop atrial flutter, sometimes the drugs will cause the flutter cycle length to slow down. So rather than going round and round the tricuspid annulus at 300 beats per minute, it's actually now only going around at 200 or 225 beats per minute. And sometimes the AV node is able to conduct from the atrium to the ventricle at 200 or 225 beats per minute. So one of the classic pro-arrhythmias that can occur with class 1C antiarrhythmics is this phenomenon of atrial flutter with 1-to-1 conduction to the ventricle. So your ventricular rate is now 200 or 225 beats per minute. And because this can occur with class 1C antiarrhythmics, we generally put people on nodal agents, some beta blocker, a calcium channel blocker or something, along with the class 1C antiarrhythmic, so that even if the flutter does slow down, the nodal agent will prevent the AV node from conducting 1-to-1 at 200 or 225 beats per minute or something. But this EKG is kind of what it looks like. You get this wide QRS at 200, 225 beats per minute. And this is actually atrial flutter with 1-to-1 conduction to the ventricle. And if you give them something to slow the rate down a little bit, the QRS becomes a little bit narrower. And you can see the underlying flutter waves here on the right side of the screen. But it's important to use these drugs with nodal agents. The one other thing that I want you to remember about class 1C antiarrhythmics is the CAST trial. And CAST was a trial that was published nearly 30 years ago now. And basically the idea with the CAST trial was that many decades ago, it was noted that people who had acute coronary syndromes, who had a lot of PVCs and ectopy, were at much higher risk of dying suddenly from VT and VF than those who didn't have a lot of PVCs. And because the PVCs were so strongly correlated with sudden death, it made sense to try to suppress the PVCs and see if that prevented sudden death. And it turns out that class 1C antiarrhythmics, flecainide and propafenone, are actually pretty effective at suppressing PVCs and suppressing ventricular ectopy. And there was a strong thought that putting people post-MI on these drugs would help reduce mortality due to sudden cardiac death. CAST randomized trial of patients post-MI who were randomized to class 1C antiarrhythmics or placebo. And to everyone's surprise, there was actually much higher mortality in the group that got the class 1C antiarrhythmics, probably because of some of these pro-arrhythmia syndromes, use dependence, QRS widening that we've talked about so far. But because of this trial here, we don't use class 1C antiarrhythmics in patients who have structural heart disease. So if you've had a prior MI, if you've F, those kinds of things, we don't use class 1C antiarrhythmics. So class 1Cs, Flecainide, Propafenone, are mostly used for treatment of Afib in people who have normal ventricles, normal ejection fraction. So young, healthy people, relatively healthy who have Afib, these are good agents to use. There is some data, I'm not going to get into this too much, with using class 1C antiarrhythmics for long QT syndrome 3, because this is mediated by sodium channels, and because Flecainide and Mexilitine block sodium channels, there is some data for using it in long QT3, but I wouldn't get too bogged down in that. So that's all of the class 1C antiarrhythmics. I know it's a lot to worry about, but the class 1As, remember, we're going to use very rarely. Those are mostly for historical purposes, except for Brugada syndrome. The class 1Bs, basically lidocaine and Mexilitine, only used for VT. And then the 1Cs, Flecainide, Propafenone, basically used for Afib in relatively healthy people.
Can I ask a quick question?
Yeah.
Where do you draw the line for the 1C agents for MI? Because I've been told coronary artery disease, I've been told MI.
Yep.
Is it like stable, non-obstructive disease, it's okay? Do you tap the person? Do you stress test them?
Yeah, nobody really knows. The truth is at CAST, we're all people who had real MIs, real acute coronary syndrome. So generally in somebody who's had a prior MI, I won't use it. If you've got Q-waves, if you've got fixed scar, if you've had stable coronary disease that's been revascularized, it's probably okay, although generally we've got other options. So I tend to use it. If you've got some coronary calcium or something like that, it's probably fine. But a lot of times if somebody's older, they've got some history of coronary, whatever, or risk factors, I'll generally do at least a stress test with some kind of imaging before starting. And if the stress looks okay, there's no provocable ischemia, then I think it's okay. But I would certainly avoid it in anybody who's had a prior MI and anybody whose EF is not normal. But that's kind of, but it is a little bit of a gray area there.
Thank you.
So the beta blockers here, you guys are, like I said, are all pretty familiar with beta blockers, and so I'm not going to get into this too much. But I put them on here, just while Logan's saying, what about LVH? Yeah, it's another good question with the 1Cs. If you have substantial LVH, like I would not use a 1C in somebody who has hypertrophic cardiomyopathy, because I don't consider that a structurally normal ventricle. If you've got a little bit of mild LVH from hypertensive heart disease, I think the guidelines say up to like 14 or 16 millimeters is probably okay. So a little bit of mild LVH is probably all right. Again, one of the things that's hard about CAST is that those were all people who had true MIs, recent MIs. And now that's kind of been extrapolated to lesser and lesser degrees of heart disease, and it's hard to know where to draw the line, but mild LVH is probably okay.
Dr. Merchant, I'm sorry, one more question.
Yeah, go ahead.
Do you ever use the Flecainide for like people with symptomatic PVCs or a high PVC burden in the absence of structural heart disease? Or
yep, it can be pretty useful for that. So if you have people who have a lot of bothersome PVCs, they don't want to get ablated or that kind of stuff, it can actually be very useful for that, because they are great for getting rid of PVCs. It's just that they can also increase mortality in people with structural heart disease. But for idiopathic PVCs and people who have structurally normal hearts, they can work quite well. And there, if you're not using it for the atrial arrhythmia and you're not worried about slow flutter, you don't have to use it with a nodal agent. You can just use the 1C by itself. But they do work quite well in that setting. All right, so we'll keep moving here. So the beta blockers, I'm not going to get too into. You guys are all very familiar with beta blockers. For arrhythmias, we use them mostly for rate control of atrial fibrillation. Also important as part of treatment of coronary disease and heart failure, because they do reduce the risk of ventricular arrhythmias also. All right, so we're going to move on to the class 3 antiarrhythmics, which is the other big class of antiarrhythmics that we use. The class 3 antiarrhythmics are Amiodarone, Sotalol, Dofetilide. They are all primarily potassium channel blockers, although you can see Amiodarone here has a whole bunch of effects. Sodium channel blockade, it's got some beta blocking activity. Because it blocks potassium channels, it can prolong the QT a little bit, but the risk of torsade from those early depolarizations that we talked about before is very low with amiodarone. Even if the QT does get a little bit long, some of that may be because it does have some calcium channel blocking activity. We don't really know. But even if the QT is long, amiodarone tends to be pretty safe. Amiodarone you can obviously use for Afib, you can use it for VT, you can use it for a whole host of arrhythmias, but amiodarone's obviously got a lot of toxicities that are important to remember. You guys are all pretty familiar with these, but obviously a thyroid toxicity is a big one that we worry about. Amiodarone can inhibit peripheral T4 to T3 conversion. It can cause both hypothyroidism by failure to escape from the Wolff-Chaikoff effect when you get a massive iodine load. Most of the toxicities of amiodarone are because it does have a lot of iodine in it, and that can affect the thyroid. It can also cause hyperthyroidism because the iodine load can cause hyperthyroidism due to the Jode-Basedow effect. And you can also have autoimmune hyperthyroidism. So amiodarone can do a lot of different things to the thyroid. Most common people who have been on amiodarone for some time for ventricular arrhythmias is a mild degree of chronic hypothyroidism, and generally a little bit of thyroid replacement will take care of that. It can cause pulmonary fibrosis. Probably the most sensitive way to monitor for that is by getting annual PFTs in people who are on it chronically. The DLCO is probably most effective, although it can be sometimes just logistically hard to get PFTs, and sometimes chest imaging, X-rays or chest CT can also be useful. Do want to monitor LFTs chronically for once a year or something for people who are on amiodarone chronically. Although fulminant cirrhosis is pretty rare. And the one thing I will say is this comes up all the time. People will be in the CCU or whatever. They're on IV amio for VF or VT or Afib or whatever, and they get a little bit of bump in their LFTs and everybody freaks out and stops the amiodarone. It's pretty unusual to see significant acute liver injury from amiodarone. Those people are almost always sick for other reasons. They're shocky, they're on other meds, and it's usually all that other stuff that's causing the liver function to be abnormal. It's rarely the amiodarone. It's worth thinking about, but my sense is that that pattern of liver injury in people who are sick and in the hospital for other reasons gets attributed to amiodarone probably more frequently than it should. Amiodarone in older people, when they're on it chronically, can cause a fair number of neurological and tremor and ataxia, and that's worth thinking about. But generally for outpatients who are on amiodarone, we do monitor thyroid tests, liver tests, and some kind of pulmonary evaluation. I generally do it about once a year or so, but those are important to remember. Sotalol is a class 3 antiarrhythmic that is a much more pure potassium channel blocker. It does have a little bit of beta blocking effect, but it's mostly a potassium channel blocker. And because it's mostly a potassium channel blocker, it does prolong the QT interval. It prolongs the action potential because it makes class 3 longer by blocking those potassium channels that are responsible for repolarization. You can use Sotalol for both Afib and VT, but the big issue with Sotalol is reverse use dependence. The same is true for Dofetilide. I would think about Sotalol and Dofetilide as being very similar. They basically have the same mechanism, both potassium channel blockers. They can both prolong the QT interval. They both have reverse use dependence. Really, the only difference between Sotalol and Dofetilide is that for people who have very bad ventricles, who have the negative inotropic effect of Sotalol can sometimes make their heart failure worse, whereas Dofetilide tends to have less negative inotropic effect and tends to be pretty safe even in people with advanced heart failure. And so sometimes it can be useful to use there, but it may be a little bit more effective for management of Afib, but you do have to be in the hospital for 3 days, as many of you will see when people come in for Dofetilide initiation. So we don't really use Dofetilide because it can be kind of a pain because you have to get admitted to use it. But it can be helpful in people who have significant LV dysfunction if they won't tolerate Sotalol. But basically, I would think about Sotalol and Dofetilide the same way. Potassium channel blockers can prolong the QT, and they're both renally cleared. So let's talk a little bit about the pro-arrhythmic effects of class 3 antiarrhythmics. And here we're talking mostly about Dofetilide and Sotalol. But because Dofetilide and Sotalol can block potassium channels, and specifically they block a potassium channel called IKR, which is this one right here, which is responsible for repolarization. So if you block this channel, you don't repolarize as quickly and the action potential gets longer. If the action potential gets longer, you're more likely to have those early after depolarizations that we talked about, and that can result in R on T phenomenon and the onset of torsade in the setting of prolonged QT. So the pro-arrhythmic risk that's important to remember for class 3 antiarrhythmics is torsade due to early depolarization. And the reason we call this reverse use dependent is that it tends to happen more commonly at slow heart rates. Remember, we said that the class 1C antiarrhythmics, the toxicity tended to happen more at high heart rates because the class 1C antiarrhythmics, Flecainide and Propafenone, bind to open channels. In contrast, the toxicity of Sotalol and Dofetilide is more common at low heart rates. And the reason for that is that when you're relatively bradycardic, this channel here, IKR, is the primary channel that's responsible for repolarization. As your heart rate goes up, let's say you get out and exercise, you need to depolarize and repolarize more quickly so that you can get your heart rate up without having torsade. And the way that your body allows you to repolarize more quickly at high heart rates is that other repolarizing currents, specifically IKS, kick in at high heart rate. So at high heart rate, both IKR and IKS are working, whereas at low heart rates, it's mostly IKR that works. And so at high heart rates, you don't have to worry so much about drug-induced long QT because IKS is also working, whereas at slow heart rates, IKR is the only one that's working. And so if you block that, you run the risk of developing significant QT prolongation. Females, because they have a baseline longer QT, tend to be more at risk for torsade from class 3 antiarrhythmics. Bradycardia, for the reasons that we talked about, is a risk, and low K and low MAG can also prolong your QT interval. And so those are all risks of torsade in the setting of class 3 antiarrhythmics. So class 3 antiarrhythmics, reverse use dependence, mostly at low heart rate. Class 1C antiarrhythmics, use dependence, mostly at high heart rate. The class 4 antiarrhythmics, we're not really, again, going to talk too much about, but these are the calcium channel blockers. Based on the Vaughan-Williams classification, it's actually mostly the non-dihydropyridine calcium channel blockers that are included here, verapamil, diltiazem, because those are the ones that do have some effect on conduction and slow AV nodal conduction. The dihydropyridine calcium channel blockers, the amlodipine, nifedipine, felodipine, have almost no effect on cardiac conduction. They're mostly peripheral calcium channel blockers and work for management of hypertension. But obviously, you can use verapamil and diltiazem for rate control of AFib, which is when we tend to use it most frequently. So again, we're going to try, obviously, this is important, so I'm going to highlight this again. If you think about an action potential here, phase 0, 1, 2, 3, and overlay that on an ECG here, here's the QRS, and here's the T wave. The QRS corresponds mostly to phase 0, which is mediated by sodium channels. If you block those sodium channels with class 1C antiarrhythmics, Flecainide and Propafenone, you can make the QRS wider. And that's the major toxicity is QRS widening, which is use dependent. In contrast, if you block potassium channels here, you make the action potential duration longer, which prolongs the QT interval. And the major toxicity of Sotalol and Dofetilide is QT prolongation, which can result in torsade. So QT prolongation, class 3 antiarrhythmics, QRS widening, class 1C antiarrhythmics. In the next couple of minutes here, we're going to finish up talking about a few other drugs that don't fit neatly into the the Vaughan-Williams classification, but we do use for management of arrhythmias. Digoxin, we've already talked about a little bit. There used to be a lot of use of digoxin for heart failure. These days, it's mostly used for management of atrial fibrillation. It can be pretty useful for rate control of AFib, particularly in people who have a low EF and who don't tolerate nodal agents because of blood pressure. Digoxin can be helpful in that setting. Digoxin blocks the sodium and potassium ATPase. And if you remember, the sodium potassium ATPase pumps sodium out of the cell and potassium into the cell. If you block the sodium potassium ATPase, you get a buildup of sodium inside the cell. And if you build up sodium inside the cell, what happens is that there's a sodium calcium exchanger, which starts to work in the opposite direction to try to pump some of that excess sodium out of the cell. And if you pump excess sodium out of the cell, you actually end up pumping calcium into the cell. And the way that digoxin really works, people used to use it as a bit of an inotrope because the thought was that it enhanced cardiac contractility. And the way it did that was by creating an influx of calcium into the cell. The problem, in part from a rhythm point of view, is that if you build up calcium inside the cell, as we said, that can predispose you to those delayed after depolarizations. And those delayed after depolarizations, if you get dig toxic, can create arrhythmias. You see this frequently on an EKG. when people are on digoxin, they get these sort of saggy looking ST segments as if somebody put their finger in the end of the ST segment and kind of pulled it down a little bit. This is known as digoxin effect. This is pretty classic for people who are on dig, but this dig effect is normal. This does not necessarily imply dig toxicity. Just because you see some signs of dig effect does not mean that somebody's toxic on digoxin. The pro-arrhythmic effects that go along with digoxin, if you do end up dig toxic, are all due to delayed after depolarizations because of buildup inside the of calcium inside the cell. And classically, the two forms of arrhythmia that you can get are atrial tachycardias. Sometimes atrial tachycardias with AV block. Digoxin can cause both AV block and also cause the atrial tachycardia. And then more classically, but rarely, you can actually have bidirectional VT, and that's what this looks like. This is VT in two different morphologies, and this occurs due to calcium overload and delayed after depolarizations in the setting of dig toxicity. The two scenarios where you see bidirectional VT, one is dig toxicity, and the other that's worth remembering but quite rare is a syndrome known as CPVT, or catecholinergic polymorphic VT, which can also give you bidirectional VT. But bidirectional VT is pretty classic for dig toxicity. Adenosine we use pretty frequently for treatment of arrhythmias, and so I included it here. It binds to G protein coupled receptors and actually hyperpolarizes the SA node and the AV node. The reason we use adenosine for arrhythmias is that it will transiently block conduction through the AV node by hyperpolarizing the myocytes. Any arrhythmia that is AV node dependent should terminate with adenosine if you give it properly. AVNRT, AVRT, even some atrial tachycardias, even though they are not AV node dependent, some atrial, about 30% of atrial tachycardias will actually terminate with adenosine, and we don't really know why that is. So just because a rhythm terminates with adenosine doesn't necessarily mean that it's AV node dependent, but all AV node dependent rhythms should terminate with adenosine. You got to be careful giving adenosine to somebody who's had a heart transplant, or if they take theophylline, which no one does these days, but because transplant recipients are denervated, the effects of adenosine can be potentiated. So whereas in somebody who doesn't have a heart transplant, we'll often start out with 6 milligrams of adenosine and then 12 or 18 or something. If you're going to give adenosine to a transplanted heart, be careful with it. Sometimes you start with 3 milligrams rather than starting with 6. You guys are all pretty familiar with adenosine. If you're in SVT like this and you give somebody adenosine, it should terminate. If it's not an AV node dependent rhythm, say it's atrial flutter, what you'll see is that you're in flutter here, you give somebody adenosine, block the AV node, and you should be able to see the flutter waves. And then once the adenosine washes out, the flutter will come back just the way it was before. The most common thing that we see when people consult us and they've given somebody adenosine, rightly so, for a narrow complex rhythm, and you say, what happened with the adenosine? They'll say nothing. And that usually means that the adenosine wasn't given properly. And you've got to give it through a pretty big IV. You've got to do a big flush behind it. Often I'll push the adenosine and then lift the arm up in order to help get the adenosine into the circulation. But because it does dilute pretty quickly, you've got to get a good bolus of adenosine into the heart. But if you give it properly, you should always see AV block 100% of the time. So if you don't see AV block, try giving it again, try giving it through a better IV, bigger flush, give a higher dose, but you should always see AV block with adenosine. Ibutilide is a medication you'll also see us use pretty frequently on the EP service. It's only available IV. It's a class 3 antiarrhythmic. You give it as an infusion, you give a milligram over 10 minutes. It's usually pretty safe to use, but because it is a class 3 antiarrhythmic, it can prolong the QT interval. The two areas where ibutilide can be helpful is one, you'll see us give it to people. Let's say somebody comes in for a cardioversion, you shock them at 360, you're unable to get them into sinus rhythm because they've got a high threshold, a high cardioversion threshold. If you give somebody an infusion of ibutilide, it actually lowers the threshold for cardioversion. And then if you shock them again at 360 with the ibutilide on board, usually it'll allow you to get them back into sinus rhythm. So in situations where you're having a hard time cardioverting somebody, ibutilide can be useful. The other area where it can be helpful, and you guys should keep this in mind, if you're seeing patients in the CCU or MICU or something like that, who have relatively recent onset AFib or AFlutter, and they're not tolerating it well, you want to try to get them back into sinus rhythm. but they've eaten, you don't want to cardivert them to get today, whatever, you can't do it, you can't sedate them for cardioversion. Sometimes giving Ibutilide for people who have relatively recent onset of atrial arrhythmias, it can be pretty effective. Probably 60 or 70% of the time, it'll get them back in sinus rhythm, and you don't have to sedate them or to cardivert them. So it can be helpful to keep in mind for that reason. You do have to monitor people on telemetry for 3 to 4 hours after Ibutilide to make sure that the QT interval normalizes, because it can prolong the QT interval, but otherwise it's a pretty safe agent to use. Isoproterenol is another agent that we use pretty frequently for arrhythmias. Isoproterenol is a beta agonist and it increases the heart rate. It can be useful for people who have symptomatic bradycardia. The one situation where it's useful to use, and if you think back to the pharmacology that we just talked about, let's say somebody gets put on azithromycin or erythromycin or something like that, and they come in, they're having episodes of torsade because they've got QT prolongation from whatever antibiotic or whatever they got put on. If you're trying to temporize and prevent episodes of torsade because they've got a prolonged QT, Isopro can actually be very helpful for that. Remember that we said that drug-induced torsade, both with Sotalol and Dofetilide, but also most other drugs that prolong the QT interval, all do it the same way by blocking IKR. And remember, that tends to be a reverse use-dependent phenomenon, meaning it's more likely to occur at slow heart rate. So if you can do something to get the heart rate up, IKS, that other repolarizing current, kicks in, and it allows you to narrow up the QT, and it makes you less likely to have torsade. So for somebody who has drug-induced long QT, who's having runs of torsade, the drug of choice is isoproterenol to get the heart rate up, and that'll usually, if you drive the heart rate up to 100, 110 beats per minute, it'll usually prevent further episodes of torsade, and it allows you time to let the whatever the drug is that caused the long QT to wash out, and then you can get them off the Isopro. But for drug-induced long QT, the drug of choice is isoproterenol to get the heart rate up to counteract that reverse use-dependent phenomenon. I think we've probably only got a couple of slides left here and we'll be done. I do want to make one mention about AFib with WPW. You guys have all heard lots about this, but if somebody has AFib and WPW, they end up with these very weird, bizarre-looking EKGs where their rhythm is irregular, but it's also wide complex, but the QRS complexes will vary depending on fusion down the AV node and fusion down the accessory pathway. If you see somebody come in with AFib with WPW, often it's because their WPW is not previously diagnosed and it's a new diagnosis. But this happens about once a year. You guys will see somebody in the ER or something like that. If you see somebody with AFib and pre-excitation and they're hemodynamically even remotely unstable, just cardiovert them. It's usually the safest thing to do. If they're reasonably stable, you want to avoid using AV nodal agents because that'll facilitate conduction down the accessory pathway, and you can conduct very rapidly and precipitate VFib from the AFib. So you can either cardiovert. Historically, the drug of choice has been Procainamide because it slows conduction both through the AV node and through the accessory pathway. The truth is Amiodarone is also probably pretty safe in this situation. But if there's any doubt about WPW and AFib, just cardiovert. It's usually the safest thing to do. Get them back in sinus rhythm. You'll see the delta waves on the EKG and take it from there. So to summarize here, for people who don't have any structural heart disease, for atrial fibrillation, the kinds of people we see as outpatients, the class 1Cs, Flecainide and Propafenone, are good to use. Dofetilide Sotalol can also be useful. If you do have structural heart disease, you can't use the 1Cs, and so Dofetilide and Sotalol are probably the drugs of choice to use in people who have reasonably normal kidneys. If you've got bad kidneys and structural heart disease, really Amiodarone is the only drug that you can use, and the options are limited other than ablation. But if you do have structural heart disease and renal function's okay, Sotalol and Dofetilide can be reasonable options. I'm not going to talk too much about this pill in the pocket thing. It's mostly an outpatient, but I do just want to mention it. For some people who have very rare episodes of AFib, like once a year, you can take a high dose of a 1C if they've got a structurally normal heart, either 300 milligrams of Flecainide or 600 milligrams of Propafenone, and it can be pretty effective at cardioverting them and getting them back to normal rhythm. And people will just take a pill in the pocket once or twice a year, and it saves them from having to come in for cardioversion. We do have a small number of outpatients that use this strategy, but it's pretty selective. I do want to mention for people who have VT and recurrent ICD shocks, the reason that we almost always jump to using amiodarone as an initial drug, even though it is toxic, is that it's far and away the most effective. There is some randomized data here that if you have people with recurrent ICD shocks and VT, and if you compare beta blockers to Sotalol or amiodarone with a beta blocker, amiodarone with a beta blocker is far and away the most effective drug. There's no question that despite its toxicities, it's the most effective oral antiarrhythmic we have, and that's why we use it so much. So I think we've already gone through most of this. These are just summary slides, but I do just again want to highlight Class 1C antiarrhythmics. I want you to remember the pro-arrhythmia syndromes, slowing of atrial flutter with one-to-one conduction, which is why we use them with nodal agents, and the CAST trial, so don't use them in patients with structural heart disease. Digoxin can cause calcium overload and bidirectional VT. And the Class 3 antiarrhythmics and even some of the Class 1As can cause QT prolongation and torsade due to early after depolarization. So these are important to remember. So I think that's the last slide. We probably have a couple minutes if anybody else has any questions. I know that's a lot to digest in a short amount of time, but hopefully it highlights a lot of stuff that you guys have already heard before.
The preceding program is copyrighted by Emory University.